A warm welcome to this series of video presentations on the role of bisphosphonates in the treatment of Paget's disease of bone. So my name's Stuart Ralston, I'm chairman of the Paget's Association, and we're presenting these videos in celebration of Paget's Awareness Day, which is on the 11th of January 2021, marking the 207th anniversary of Sir James Paget's birth. Now, today it's my pleasure to welcome Professor Ian Reid, who has very kindly agreed to talk to me about some of the clinical trials he's conducted in Paget's. So welcome, Ian. We know each other very well, obviously, but maybe you could say a few words about your career for anyone that might be watching that isn't familiar with the field. Thank you.
Chance to be involved. I'm a Kiwi, so I trained in endocrinology here in Auckland, and I had two very important mentors in that role. One was Professor Russell Fraser, who had been Professor of Endocrinology at the Hammersmith in London, and in retirement had come back to Auckland, and he had a very keen interest in Paget's disease, and he also had access to an unregistered medicine that we called APD at that time and subsequently became pamidronate. And the other person who drew me into Paget's and worked closely with Russell was Professor Ian, who was Professor of Endocrinology here. So at that time, really because of where Auckland was peopled from, we had one of the biggest Paget's clinics in the world, along with places like Manchester and Sheffield, which of course was where many of the New Zealanders came from. And so because of the genetic nature of Paget's disease, New Zealand and the north of England have a lot in common and a lot of Paget's disease. So it was there I started seeing lots of patients with Paget's disease and importantly treating them with potent bisphosphonates.
Okay, thanks, Ian. Now, I think it'd be fair to say that one of the leading contributions you've made in this area is with the studies you've conducted with zoledronic acid or zoledronate in Paget's disease. Now, perhaps I could take you back to 2005 when you published your seminal New England Journal of Medicine paper, which compared 5 mg zoledronic acid with rezedronate in Paget's disease. Now, the thing I wanted to focus initially on was that prior to this, there had been some studies with zoledronate in Paget's, but really they were using tiny microgram doses. And then you came in this study with a 5 mg dose. I think it was tenfold higher than previously had been studied. And I wondered how that had come about.
I mean, as you know, there's no real money in Paget's disease. There aren't enough people who have it for companies to make money. And so I think the focus of developing zoledronic acid was indeed for treating osteoporosis, which is a much more prevalent problem, and also for managing cancers that spread to bone. And so they had started a program with, as you say, microgram doses of Paget's disease, and that was used initially, microgram doses of zoledronate, which was used initially in Paget's disease. And then I worked with them on escalating that dose in the context of osteoporosis. And so we did a phase 2 trial with zoledronate and osteoporosis, where we started with quarter milligram doses and worked up to 4 mg doses. And meanwhile, in the cancer program, they were going as high as 8 mg doses. And what became clear was that the bigger doses were much more effective and also that they were safe. And so when we designed the Paget's study, we took the 5 mg dose, which was the dose they had decided to take into the osteoporosis phase 3 program, and use that. And it proved to be both safe and effective.
Okay, thanks. Well, just as well you did choose the 5 mg dose, because we know now it is pretty effective. Now, the New England paper showed clear superiority of zoledronic acid as compared with rezedronate in suppressing elevated bone turnover in Paget's, and also benefits in terms of controlling pain and some aspects of quality of life. Now, I was interested in the fact that you studied quality of life and pain, because up until then, many studies in Paget's disease had really had focused really only on biochemical markers of bone turnover. So I wondered why you did that, why you thought it was important to look at those aspects, and why you factored them into your trial. Thank you.
Both of us, you and I, agree that it's really important that we study things that matter to patients. If you just make someone's biochemistry normal and it doesn't change the course of their disease, then that really isn't going to make any difference. And I guess this was a principle I had taken on board from Paget and Russell Fraser, who spent a long time studying the radiological effects of treating Paget's disease and determining whether you could actually heal the lesions in bone and stop them progressing down the bone. And with pamidronate you could, whereas with atidronate, which they'd used previously, the evidence for that was not at all convincing. And so I was actually quite keen to have radiographs in the study, but that was far too complicated to engineer. But we did, if you like, the next best thing, or some people would say a more important thing, which was to assess the effect of treatment on quality of life. And as you say, I think that was one of the landmark achievements of the study, was to say, well, you don't only normalize the biochemistry, which is nice, but actually patients feel better. So the two things are tracking together. You probably really are controlling the disease, not just biochemically, but in terms of the way it impacts on patients' lives.
Many thanks, Ian. Well, I think it was a good thing you did that, as you've mentioned. It shows that not only is the drug good at suppressing bone turnover, but it helps patient symptoms, which obviously is important. Now, the other very striking thing about zoledronic acid is a very long duration of action. And that was very nicely demonstrated by your JBMR paper in 2008. Now, one thing that was a little surprising about that paper, which I might ask you about, was the fact that clinical relapse, which I think was recurrence of pain needing further treatment, occurred in a proportion of patients, but the biochemical markers had remained suppressed at that point. And I wondered if you had any insights into what you thought was going on then and why that might have occurred.
In retrospect, I think they were not probably real relapses. So the patients after the end of the study during the follow-up were being principally managed by their own doctors. And I think a lot of these patients, well, certainly the ones in Auckland, had previously been managed with pamidronate, and they'd got into the habit of having an infusion every couple of years, which would make them feel better. The pain would go away and then it would gradually come back again. And certainly I saw my own patients coming back saying, I think I'm ready for a top-up dose, doc. And in the case of pamidronate, usually the biochemical markers had come back up, but actually what we were finding in zoledronate, as you said, was the markers hadn't come back up at all. And so then we got back into the practice of actually doing bone scintigrams on these people at that time. And what we would find in almost all cases was that there wasn't any evidence of reactivation of disease on the bone scintigraphy, which is the most sensitive measure we have. So both the scintigraphy and the biochemical markers remain normal. And I think the fact that people thought they got back some aches and pains was probably reflecting the underlying arthritis, which Paget's disease leads to. And I think since many clinicians using zoledronate have realized that the effect really is very long lasting, that we give top-up doses much, much less frequently, and patients really don't expect them to. Also, I guess now, 15, 20 years later, we're dealing with much more mild Paget's disease than we were then. And so patients, for the most part, and we published a recent series of about 110 patients, and I don't think any of those required retreatment. They have a treatment, their markers come normal, their scans come normal, they feel great, and basically in 99% of cases, the problem is solved with that single treatment, which of course is vastly better than we ever dared to imagine would happen, because in the past, Paget's disease always required retreatment, whether you were using oral agents or other intravenous agents.
Thanks very much, Ian. And it's interesting what you say about the bone scans, because I must admit that's something that I do use myself to figure out if there is activity in considering whether retreatment might be necessary. Okay, so it's been very good to talk to you, and I think that clinicians and patients alike owe you a debt of gratitude for the fantastic research you've conducted into Paget's disease. But one thing I wanted to ask, my final question, do you think there's going to be a better treatment than zoledronic acid, or do you think this is as good as it gets? I'd appreciate your thoughts.
Well, it might be as good as it gets. We now have an agent called denosumab for treating osteoporosis and bone cancers, which is more potent than Paget's than zoledronate, but it does not last anything like as well. And you've been kind enough to publish some of our work using that agent in Paget's disease, and it really is not anything like as good as zoledronate. It may be that other companies develop more potent or more long-lasting bisphosphonates, in which case we would be very interested in trying them in Paget's disease, but I see no sign of that at the present time, because zoledronate pretty much meets the needs that we have in the various clinical areas. So I suspect that this probably is going to be the final definitive treatment for Paget's disease. But of course, in medical science, you never know what's going to happen in 5 or 10 years' time. So we will wait and see.
Okay, Ian, many thanks once again for your time today. It's been great to talk to you. Hopefully you will still continue to research into Pagets for many years to come, because there are some questions that remain unanswered. But thanks once again. Thank you.